So the validation study plan, after we had developed that algorithm, we locked the algorithm, we developed a prospectively defined analysis plan. We then looked at an independent cohort of patients from the PREDICT trial. We used a case control definition based on the work that Alexandra had done at CRF with quantitative coronary angiography, did the RT-PCR on the 23 genes, and then the primary endpoint was to look at whether the score significantly predicted the likelihood of having obstructive disease using receiver-operator characteristics analysis. And we also looked at whether it was additive to, for example, the Diamond-Forrester formulation of how to assess risk based on age, gender, and chest pain type. And we did the analysis at CardioDx, and also externally, Nick Shork at Scripps performed the analysis, and we used his numbers, though they were the same as ours. And so when you look at the primary endpoint in the validation study, what you see is that the overall result is one that's highly significantly better than random. And importantly, the p-value for both men and women were independently significant. So both arms of the algorithm, as I showed you on the earlier slide, both work well. When we looked at Diamond-Forrester, I think Alexandra did a nice job covering this. One final point is that this was validated in a large independent set by Bernie Chapman and coworkers. And also, the variables shown here, age, gender, and chest pain type, really represent the most significant clinical factors that we observed in the PREDICT population as well. So it seemed like a good match. So when you look then in ROC analysis at a comparison of the Corus CAD algorithm score with Diamond-Forrester compared to Diamond-Forrester alone, what you see is that there is a statistically significant increase in the area under that curve. This is quite a stringent statistical test to show that you have an improvement in the accuracy by which you identify patients. The question then is, though clinically, is this really meaningful? And so in order to look at that question, we used reclassification analysis. I think first, just to show that from the validation study, you can show here that the range of likelihood of obstructive disease as a function of algorithm score ranges from a low of about 10% at very low scores all the way up to close to 80%, and that actually a third of the patients in the validation study had scores of 15 and below. That put them in this low risk bucket, as Alexandra mentioned.